Tokyolive Endoscopy 1. Hello, everybody. It's a great honor and pleasure for me to moderate this very exciting session with two of my oldest friends and colleagues and teachers as well. So it's about the future of flexible endoscopic surgery. I think the topic is excellent. And we'll have the first speaker, Haru Inoue. I don't think any of the two needs any introduction because they are so famous worldwide. So Haru is my teacher in poem, for example, and of many other people. So Haru, we have been confined to the mucosa, submucosa, and your title is there more than ESD? To what extent do we need transmural resection? Haru, please.
Thank you so much. A kind introduction to me. And I would like, let's share my slide. So before going to my lecture, I really appreciate Thomas, your moderation of this session. Everybody knows Thomas, so he organized the endoscopy on air, and it was last year started, and this year also a big impact to the endoscopy society worldwide, and his idea and the organization and produce we once again say congratulations. So I'd like to talk about the flexible endoscopic surgery and the current and the future. This is my COI, and so this is yes, the advancement just in a GI tract, not the US, not the FNA or some other. But anyway, so this is the development, the therapeutic procedures in the GI tract. So ESD has a big impact for us. Dr. Ono is as long as I know, so he's the first guy he did the ESD, and the using the ESD technology, we can do the submucosal endoscopy. So now we are starting from the poem procedure. Now we can apply the submucosal endoscopy technique to our poet, the G poem, or the thinker poem, and the diverticular poem. So I would like to talk very shortly about the poem procedure. So poem was reported at 2010, 11 years ago. And after that, so Chinese group and myself reported the poet procedure, Peroral endoscopic tumor resection. And like this way used to be this kind of submucosal tumor derived from the muscle layer was treated by trachoscopically. This is an esophageal submucosal tumor, but now we can do it endoscopically. So like this way, mobilizing the submucosal tumor in a submucosal space, and then cut the muscle layer endoscopically, and then we can take out the tumor. We can take out the tumor through the mouth. So of course, there is a big defect of the muscle, but we preserve the mucosal layer as a natural barrier, so nothing bad happen. Just close the mucosal entry. So this is my colleague will report our data. Less than 4 centimeter tumor is a good indication of this procedure. So Chinese group reported that they have huge data, and their data is also good and similar to others. And the unblocked resection rate is 90%, and they also recommend the tumor size. Indication of this procedure is less than 4 centimeters. Philip Chu of the Hong Kong, he also reported a similar results. So success rate is more than 90%, and the indication is a less than 40 centimeter tumor. But anyway, so surgical procedure moved to a flexible endoscopic surgery. And the one of the offshoot of the poem is a gastric poem. This is a schematic drawing of the Peroral myotomy in a submucosal tunnel. The first case was done myself and together with Moe and Kashab in Johns Hopkins. This is a photo right after procedure. Dr. Stavropoulos was there. And the Moe and Kashab also, he reported his initial series in a GIE. This is our case in a Japanese patient. So junction was so tight. So this is a kind of a spastic pylorus stenosis. And then we did in a submucosal space, we did the myotomy, and finally you can see a very thin muscle bundle. This is a muscle bundle in a duodenum bulbs. So so side you can see a cut end of the thick pylorus muscle. Anyway, so we complete the procedure. And then after that, we close the mucosal entry. In this case, we use a loop and clip technique to close the mucosal layer tightly. So another good application of a submucosal endoscopy is a thinker poem. So this is a case of a thinker. You can see a diverticum at the level of the neck of the patient. The endoscopically, we can see so diverticum like this. So used to be, we endoscopically cut a mucosa and muscle layer, but now we can do it. So just so injection first, and place the mucosa cut only on the top of the septum, and then now we started the myotomy alone and independently. So we don't cut the mucosa, we just cut the muscle layer. And then in a submucosal space, so you can see the muscle layer, then we complete the myotomy. So used to be we cut the mucosa, so it's we are so nervous to close the mucosal defect, but now we can easily close the mucosal defect because mucosal defect is only on the top of the septum, so very easy to close. And then so maybe 1 or 2 months after procedure, it looks a septum closure. It looks very good. This is a volume swallow after procedure. No more diverticum. We can see it. So next, I would like to talk about the diverticum, esophageal diverticum poem. So this is a case of an epiphrenic diverticum in the across the esophagogastric junction, but together with the esophagogastric junction outflow obstruction. So, okay, this is a case. The volume swallow, you can see a tight junction, and also some size of diverticum. So endoscopically, we can see manometry demonstrate not so high, but the ILP increases a little bit. Not so much, not so much. So ILP is in this case is 8.3, but the endoscopically outlet looks so tight, like this way. Now I try to pass the endoscope through the through junction, but I feel some resistance to pass the endoscope. So ILP is, I think, endoscopically high. Anyway, so in this case, we create a submucosal tunnel. And then, so in this case, we are trying to resect the diverticum endoscopically, not just the septotomy. So we are trying to dissect the diverticulum. So it's a same approach to a surgical thoracoscopic approach. So this is a submucosal endoscopy. We are getting in a defect. So side by side to diverticulum mucosa. So now we are dissecting the submucosal fibers. On the front, we can see proiler, mediastinum proiler. And in order to invert the diverticulum mucosa, we place the endoscopy like this. So now we advance endoscope in the diverticulum and then a suction, and we release the snare and then catch the diverticulum mucosa itself from the bottom of it, and then put it back to natural lumen. Then after keeping the traction to inverted diverticulum mucosa, once again we try to dissect the diverticulum mucosa from the background proiler. So like this way, this is a connective tissue in between mediastinum proiler and diverticulum mucosa. Then we mobilize the whole diverticulum mucosa out from the mediastinum and then put it back to natural cavity, so demonstrated in the illustration. Then we are closing the muscle defect in the submucosal space using a needle holder. Now we catch one side of the muscle layer, and yes, it's the same to surgery. Then so this is one side, and so putting it back, and then now we're suturing the other side of the muscle layer. Okay. Then we close the muscle defect in a submucosal space. So please note the illustration in the right-hand side. So after closing the muscle layer defect, this is a totally same procedure to thoracoscopic surgery for epiphrenic diverticulum. So after this, so diverticulum mucosa was already inverted in esophageal lumen, but the inverted mucosa is so big, then I decided to cut it out using the regular smear. So of course we keep the loop at the bottom. Anyway, so we close the mucosal defect using several clips. So this is a resected epiphrenic diverticulum mucosa, and this is a volume floor after procedure. We can see some deformity, but of course, diverticulum was gone. So this is an endoscopic image several months after procedure. So one clip remained, but the epiphrenic diverticulum was gone. This is a volume swallow before and the 2 days and the 6 days after procedure. So finally, I would like to demonstrate the application of the submucosal endoscopy to the post-pom GERD. So peroral endoscopic fundoplication first case was done in 4 years ago. So far, we did 45 cases of peroral endoscopic fundoplication. So one of my colleagues reported. Okay, so actual procedure is like this, creating a submucosal tunnel, and then we approach anterior wall of the esophagus. We approach to the peritoneal cavity. On the lateral flex view, we catch the anterior wall of the stomach and make a fundoplication like this. we use a V-lock, and the proximal anchor is okay. So I can show you. So this is actual video image. So now we are dissecting the peritoneum in a submucosal tunnel. Muscle layer is already dissected. So anterior esophageal wall tunnel, and the behind you can see a back side of the left liver lobe. Now we widening the peritoneum opening, and then getting an abdominal cavity. Now we are placing the suture onto the anterior wall of the stomach. So this is a second scope inserted in a stomach. We can see a needle is coming in the stomach lumen and then going out. You can see a hiatus is open because of the previous poem. So this is the reason of the reflex. So this is a proximal anchoring in a submucosal tunnel. Now we are suturing on the diaphragmatic course, right hand side. Left side, 5 to 10 o'clock direction, we can see a mucosal tube, back side of it. Yes, and then when we prove the V-lock, we can confirm the good fundoplication, lapping cover on the open hiatus. So softly closed. So far, we this is the data at the time of 43 cases, but the technical success rate is 100%. On the pH in a poem alone group and a poem plus fundoplication group, in the F group, domestic composite score improved. So now we can do like this way, is dome fundoplication using a flexible endoscope. So this is my last slide and the conclusion of my presentation. So I think in the future, many surgical procedures will be replaced by the flexible endoscopic surgery through the natural orifice. So I think this is a good news to the patient. And the of course, these procedures is a clinical procedure, so we have to do it carefully, and step by step, and keep the safe side. But based on our experience, lots of flexible endoscopic surgery experience, we advance forward step by step. Thank you so much, kind attention.
Thank you very much, Haru. As always, fascinating. I'm always looking what step you are doing next. Well, I think a lot is centering around suturing, right? And this needle holder doesn't seem to be super easy. So is there anything more easy for the endoscopist on the market or on the future market?
Yeah, thank you so much. It's a good question. So so endoscopic needle holder suturing, it looks easy, but actually not so easy. But then that's the reason why I select the application. So so fundoplication and the so one muscle closure, two muscles, two stitch, one stitch, two stitch. It's okay, acceptable. But if we want to close the big defect, it's impossible. So we spend a lot of time. So I think, but nowadays, so many endoscopists try to develop a new suturing machine. So I think so. Some device will find a way to close the defect easily.
Thank you. You Japanese endoscopists, you're always so polite. So if a Japanese doctor says acceptable, Western doctors would say, well, pretty moderate or poor, huh? Right? So, and if something is too difficult, then the broad application is a little bit hampered. Nagi, is there anything going on in India with the suturing, simple suturing devices?
No, I think, Thomas, what you said is absolutely right. We require an easy suturing device. We don't have to have the super skill of Haru to do this. And I think what is going to come is what we're learning from the laparoscopic surgeons. They have these suturing devices which are almost automated. Some of these devices look very promising, but the problem, of course, is because they're very short on laparoscopy, it's very sturdy to do them. The trick is to try and make them longer and flexible. And I'm sure the future surgical suturing device is going to come from one of these devices, which are modified from laparoscopic suturing devices. There are many interesting ones that are available from Ethicon and so on.
I'm always wondering, you know, years ago, there were some companies producing T-tags, and they were not very difficult to place, but they didn't survive. I mean, why weren't they not further developed, Haru? The T-tag principle.
Yeah. So I think yes, T-tag is yes, theoretically simple, and the technically placement of the device is so technically acceptable. So I think it's one of the way, but I'm not sure the company's decision. So they are withdrawing, but I think still we need some if we find some improvement of the device, so still we have a chance to use it, I think.
No, I think the T-tag, the problem also comes that in T-tag, you wouldn't know what you are actually hitting beyond the wall because it was done with endoscopy. Maybe if you convert it into EUS guided T-tag, there's a possibility that you probably will be safe. I think otherwise you're hitting a vessel you don't know, you just hit and pull back the T-tag so you can rub against something.
That's right. But you know, the examples Haru was showing, you had just the muscularis in front of you, and it would probably be not so difficult, have been so difficult to pinch and anchor through. So of course, if you go through an intact wall, you don't see what's behind. But also with a needle, you know, you stick the needle somewhere and you could also hit a vessel, like with a needle holder. So, but okay, I think we can't go further into details. Haru, you already mentioned that the mucosa is the life protection for the patient and for the surgeon and so on. What's your current management if there is a mucosal leak, ischemia, and everything is open? Okay, so does the patient have to undergo surgery, or do you do endoscopic therapy, sponge, or what do you do?
So it's a very important point. And then when we start this point procedure, we are so much afraid. So late onset mucosal necrosis or some other. So if we have a big defect on the mucosa, it's a disaster. So we are so much afraid. So our solution is, the first one is a second look endoscopy on the following day of the procedure. So we just want to check the mucosal condition. And after confirmation of the good condition, we start the diet. So patient diet, we start. So just in the case that if there is a necrosis or a big defect of the mucosa, so best way is to keep the patient fasting. So the concept is like this, even when the patient has some big defect of the mucosa, if we keep the patient fasting and wait for at least 4 days and 7 days, most of the case, the big defect will recover by the surrounding tissue or mucosa itself, or so some white coat or some other. Anyway, so some yes, so our tissue will cover the defect. So most important is to keep the patient fasting. So such kind of planning is treatment is based on experience of a big leakage after surgery. For example, big leakage after esophagectomy. So if it's happened, so most important is to keep the patient fasting and give a good nutrition to the patient in a intravenous or something. So anyway, so our treatment option for the partial necrosis of the mucosa is keep the patient fasting.
Okay, yeah, it's rare, fortunately, very rare, but if it happens, it can be a disaster. And I think there are different cultures. In the US, they dismiss the patient sometimes on the same day. In Japan and Germany, and I don't know how you do it, and Nagi, we usually do a control. And if there's some mucosal problem, we keep the patient longer in hospital. I think it's worthwhile doing it. Maybe we are too cautious, but it can be a disaster in very rare cases.
You're right.
Good. Okay, so don't let's not speak about disasters only. Maybe at the end, that full transmural resection. Do you think there are many indications, or by the nature of oncology, we can only oncologically resect superficial lesions? So how much transmural resection do you think we need, at least in the upper GI tract?
Is that a question to me?
Yes.
So best application of the transmural resection is the I think in a gastric gist. It's now we can detect the some numbers of small gist. If the gist stomach gist, the gist size is more than 4 centimeters, should be resected laparoscopically. But so now we can detect so many 2 centimeter submucosal tumor gist. In such a case, we have to resect it. So at that time, so best application is the, of course, if we can complete the excision of the gist by the endoscopic muscle layer dissection or endoscopic subserosal dissection, preserving the some gastric wall tissue, then it's okay. But some of the case, so even a 2 centimeter gist exposed to the peritoneal cavity, peritoneum. So at the time, so we have to do the full layer resection. It's I think a significant number. So think about the globally, yes.
So not for the cancers, but for submucosal tumors in the stomach up to a limited size.
Yeah, but nowadays we have lots of patients who refuse, not so many, but a significant number of refusal to surgery refused patient. So in such a case, or the patient has a significant comorbidity. So at the time, so some patients select even the cancer invaded to a deeper layer. So some patients receive have to receive some local excision. Of course, beforehand we have to check the patient has no lymph node metastasis. But in such a case, so even a T2 tumor, so so patient do not want to receive surgery at the time, so one of the options is a local excision of the tumor by the endoscopic technique.
Okay, thank you, Haro. That was very interesting. Already the last answer was a step into the future. What about treating T2 tumors just by endoscopic resection? Maybe it will come. And so I can hand over to Nagi Reddy from Hyderabad, who runs one of the best endoscopy units and biggest endoscopy units in the world. And as you can see, he has a huge library behind him where he can read everything about the future. So what will be the future of endoscopic surgery, Nagi?
Yeah, so thank you, Thomas. I'd like to thank Haro for giving me this opportunity yet again to participate in this very important Tokyolive. I've been asked to talk on the future of endoscopic surgery, but let me build it up a little to where we are and what's going to happen in future. In fact, in general, if you look at what happened with endoscopy, you'll realize that endoscopy is slowly replacing surgery in many areas. Many years ago, GI bleed was a surgical problem, but no longer now. Similarly, what is happening with the pancreatic cysts of Wands and so on, And even obesity now is transforming itself from purely surgical procedures to endoscopic procedures. So I think there's a transformation which is already started. And this transformation is continuing on the area to see where minimally invasive endoscopic procedure can actually replace surgery with the hope that you're producing less tissue damage, probably better recovery, and so on. So ultimately, there's going to be an integration of endoscopy and laparoscopy together. And in my opinion, this is when we scale the heights of what's going to happen. It's going to be a lapro-endoscopic procedures. It's going to be somebody who's trained in both who are going to do these procedures, the fusion procedures. It all started, in fact, 20 years ago when Anthony Kalu and group did the first transoral peritonioscopy in animal model. We thought actually, the excitement among the endoscopists at that time was immense. And we thought we actually went into surgery. And in fact, this was the first human appendectomy that was done in our unit in 2003 in a patient who had extensive anterior wall burns. So we had to go transgastric into the stomach and remove the appendix. But then we thought this is going to rapidly progress. But since 20 years, nothing much has happened. This was a disruptive technology which was breaking barriers between surgeons and physicians, so that physicians now started thinking like surgeons, and surgeons also had to come back to some thoughts like physicians on motility disorders and so on. So this was a really disruptive technology. But then what went wrong with notes? Why didn't it progress? Why did it take 20 years for us to know that it's not the right thing? Well, one of the things, of course, is this is a famous cartoon that Anthony Kalu used to always show in his talks, the notes technique where you go through the stomach, put a balloon. We had done some of these procedures initially in human cases. We'd go in and then try and, of course, remove the gallbladder, remove the appendix. There have been several reports all over the world, especially from South America, where they were doing cholecystectomies this way, and a large randomized controlled trial comparing transabdominal cholecystectomy versus nodes cholecystectomy showed that transabdominal was better in terms of shorter time and so on. So the reason why nodes failed, in my opinion, was that we chose a wrong procedure. We chose cholecystectomy and appendectomy, which were best done through conventional methods, rather than choosing something which could have been done not by surgery, but only by endoscopy. And then came the principle of mucosal flap flap, which actually changed our approach. Yeah, this is a technique which, of course, I think Inouye has shown very elegantly in the poem, which Sumiyama and others from Mayo Clinic initially showed, that if you can make an opening in the mucosa, cut the stomach and go out this way, then what happens is that you're protecting the flap valve. Initially, we are going directly through the lumen, but now we are going through the flap flap. And because of this technique, and because you can close the mucosa as is shown in poem, you can actually protect what's happening. So you become much more adventurous to do these procedures now. Of course, we all know the famous first so-called notes procedure, and this was when notes was going off 7 years after it was first came in. When Pankaj showed this, and of course, Haru demonstrated very elegantly in human experimentation, the first case that came in. This revived notes again. And of course, these two famous studies, one in JAMA, we showed that poem was superior to pneumatic dilatation. And similarly, another study which I'll come to later, but studies showing that on meta-analysis, LS versus poem, how poem again was superior. We knew how to tackle the complications of poem, and realized that these were not actually adverse effects. One of the most important things that happened in the mentality of the endoscopists at this point of time was that we're no longer calling them as complications of endoscopy. Like a surgeon, when you cut, it bleeds. It's not a complication, it's part of the procedure. We realized that many of the so-called complications we're producing at endoscopy were actually consequences of the procedure and could be tackled endoscopically, and we stopped calling them adverse events or complications. And I think that is one important mentality that changed. But still, when you're doing procedures like poem, for example, and this is again the famous study which Thomas and all published in New England Journal, we realized that there are problems like reflex, which can't be corrected by endoscopy compared to what you can do surgically. So came poem F, again indicating that when you do something endoscopically, you can correct it endoscopically. And also we started reaching areas where surgeons don't. don't do so well. And this is, for example, in non-achalasia spastic disorders, where you don't have to cut the LEG junction. You just cut above, which is not very accessible to the surgeons. We know that endoscopy is much more superior to surgery, especially in a situation like this jackhammer. And of course, studies now showing that when this non-achalasia motility disorders are better treated endoscopically than surgically. You know that surgery endoscopy is progressing. And similarly, G-poem that Haru has shown, several studies now showing that, again, in certain situations, endoscopy may be superior to surgery, especially in situations like this. So third space endoscopy really opened up our vistas for doing more endoscopic surgery. Third space is really the space between the mucosa and the muscle, the so-called submucosal space, as you can see here. All these years, the endoscopist has been working in the first space. And then briefly during the Notes era, we went into the second space, transluminal peritonioscopy. And then, of course, came the third space, which formed the bridge between the first and the second space, so that transgastric or transcolonic surgery was not given up, and we still continued because we had the hope of third space coming in. So there was, in addition to POEM, there have been several indications: transgastric peritonioscopy, full thickness resection of subepithelial tumors, implantation of simulatory devices, ICU diaphragmatic pacing, and of course, for diagnosis of visceral neuropathies where you have to take a full thickness resection, you don't have to go to surgery. You can actually do it using endoscopy. So what has made endoscopy so successful that we're now thinking of contemplating replacement of surgery? I think it's a combination of technology, closure devices, and so on. And of course, techniques like submucosal flap. One of the reasons why Notes failed is not only because we chose conventional diseases which are better treated by laparoscopy, but also we didn't have the devices and technology which are just coming in. Even now, one of the major reasons why endoscopy is lagging behind surgery in terms of surgical procedures is because of lack of new technology and devices which are going to be ideal. We discussed some of this like suturing techniques in the earlier talk, and this is going to limitation. If we can have a real good suturing technique, there would be no difference between endoscopy and surgery, but we still don't have this. We have, of course, better scopes, water jet resolution, multi-bending, so many caps and many cautery devices like hybrid knife and so on. All these have increased our capability to do surgically oriented techniques endoscopically, but still we don't have all the tools. And of course, the closure device is the one which we have to think of concentrating in future. We have some closure devices, but I think these are pretty crude. It's difficult to close large defects, and unless we have a very good suturing device, I think the problem is going to be translating many of these into real surgical procedures. So the principles of third space endoscopy again is very important that we preserve the mucosa on the surface so that many of these procedures are done very safely. And especially, of course, stir again has been discussed, and you can see that this gap which is present is very securely closed. I think one of the most important advances that occurred in addition to POEM was this technique of stir, where you can actually resect it using this nice technique of third space endoscopy. And of course, the indications for this are increasing now. And this is further enhanced the capability to do full thickness resection. Using the same technique, you can actually do a full thickness resection and close the gap with clips. Of course, a variety of lesions, in addition to the GIST, you can have aberrant pancreas, granular cell tumors, and so on. All of this can be treated. So the impact of third space endoscopy has been tremendous, giving us this opportunity as a stepping stone to go further. For example, one wouldn't have thought that Hirschsprung's disease could be treated by endoscopy. It can be, of course, like Notes fundoplication and so on. So we have now, of course, many acronyms that we're starting to learn: E-POEM, Z-POEM, Z-POEM, and of course, esophageal stricture treatment, so-called poetry. The future is, of course, going to be increasing, and of course, the many other disorders like chronic constipation, for example, endoscopy may become the modality of treatment for placing devices which are electrostimulatory in nature. So many of these diseases which are surgical are no longer surgical with the advent of endoscopic therapy. So we come back now to the True Notes. What about True Notes that we started? I think True Notes is now actually exemplified by certain things. For example, peroral endoscopic lymph node sampling is done routinely in many units. Some of this was done by EUS guided method, but now we have true puncture of the cavity going inside and sampling the lymph nodes. Transvaginal peritoneoscopy and transvaginal peritoneoscopic procedures are still being done in many South American countries, and I think this is the area where they're expanding rapidly. We as endoscopists don't have so much experience compared to what laparoscopic surgeons do. But I think the main technique of how the so-called endoscopic surgery is going to progress is through the hybrid technique. Many years back, we wrote this editorial where you do all your procedures endoscopically, making a keyhole, going into the peritoneal cavity, and you can do everything through flexible endoscopy, but keeping a watch with a tiny laparoscope. We now have needle laparoscopes, which have very good view. In fact, we can do this even in our endoscopy rooms without resorting to surgical theaters. Tiny laparoscopes, you can watch everything that's happening, and in case there's a complication like a bleed and so on, we can use this laparoscope to stop it. So I think these hybrid procedures are going to be the future of endoscopic surgery, and this is an example of one hybrid procedure where you use laparoscopy and endoscopy. We are using this to actually take out this very vascular stromal tumor just at the G junction. It couldn't be done through endoscopy. Again, through laparoscopy, it can't be. We're combining now, watching endoscopically as through laparoscopy, we are going to resect these lesions. And you can see we can resect it. If there's any bleed, we can control very easily, either endoscopically or laparoscopically. I think this is we can see this is a very, very vascular tumor, but still we are very confident because of this combined technique. So these hybrid techniques are going to be the future, I think, because they are going to now replace many conventional laparoscopic procedures also. This is a Chinese study recently published where they did a full thickness resection endoscopic lymphadenectomy for colonic cancer in inoperable patient. Now, I think this is an important concept, and this is something that we discussed, Thomas and Harrow, in your previous talk, that oncologically it's not acceptable to do a full thickness resection, especially if there's lymph node involved. But what happens that if you have the ability to actually trace all the mets in the lymph nodes, that you have an imaging technique, or even endoscopically, we can actually map out all the involvement oncologically, and then using endoscopy, you can have this combination of full thickness resection with lymph nodal resection also doing combination. This is very futuristic. Currently, it's not acceptable oncologically, but I think we may get to a time when this can be done. And this may be the future that we should come to see. So I think the future is going to be hybrid theaters. We already have this in our institute now, where you can, we have at least a few theaters which have both endoscopy and laparoscopy integrated. We call this the so-called endolap MIS ORs, where you can do both. So whenever you're doing a procedure, you can easily hook on a laparoscopy or hook on endoscopy in addition and continue the procedure. So I think in future, hybrid theaters are going to be very common in most of the surgical units or endoscopy units, so that you can combine both. I think it's important also to mention that since most of the concepts related to therapeutic endoscopy were conceived and developed in the context of surgical science, it's both appropriate and necessary that surgeons should continue to have the involvement in modality. For example, in our unit, it's a combined unit where both surgeons and endoscopists are working together. It's only not physician endoscopists. And I think it's very important that this combined involvement for this to proceed further. In fact, now SAGES has put in their training system an integrated flexible endoscopic training during surgical residency is becoming a part. So I feel that future of endoscopy is going to be driven both by aggressive endoscopists and surgical endoscopists, and mainly both of them coming together. And finally, just to show you a futuristic video that we made in our institute. So if you have, this is a patient in whom suspected has abdominal pain, takes a capsule which says acute appendectomy. The surgeon, endoscopic surgeon, actually landed on the rooftop, goes inside, and then of course you have this now portable flexible endoscopes, goes inside, makes an opening in the stomach, and then of course removes this appendix, and the patient stays home. This is of course very futuristic, but hopefully some of this at-home surgeries in this COVID era may become a possibility. Thank you very much for your attention.
Thank you very much, Nagi. I love your videos, which always are part fun and also give us hope for the future. If you allow me to be a little bit less optimistic, could it be that, our industry partners have become a little bit lazy? Because one of the reasons why the tunnel was so readily accepted is that we didn't hardly need any new instruments. So we could use what was already there. But if we look at nodes, there was not really something developed. And maybe that's the problem, that either the endoscopic world tries to do everything by endoscopy, that's the nodes failure, or the laparoscopic world is pressed into endoscopy. So we need two arms with a machine, and we fiddle around with a knife, which is much less precise than if we use one endoscope and one knife. So we have to have people like yourself and Haro to bang the heads together of industry and surgeons and endoscopists, that something different comes out. That's would be my vision.
I think, Thomas, the problem is that we have depended too much on industry, and industry is looking at very short-term gains. If they're going to develop an instrument, the reason why nodes didn't develop or nodes instruments didn't develop was because industry initially put in a lot of some money they put in. They expected that within 3 or 4 years or 5 years, they'll get back their returns, especially some of these giant companies. But when they found this was not happening, they quickly withdrew from the field. I think what we should do, what I believe that endoscopists in general would have to, I think, get their funding from universities. If we can get major funding from universities which are not actually waiting for this to be commercialized and quickly get the returns, because we lost 20 years now. 2000 was our concepts, and now we lost 20 years. So 20 years ago, if most of the funding came from either the governments or the universities, I'm sure we had instruments with which we would have been capable of doing some of these procedures at least.
Well, I think maybe it was a little bit unrealistic. If you look at industry, it takes 5 years to develop a new guide wire with all those accreditation processes. So to develop something completely new within 2 years was maybe a little bit unrealistic. But I agree, we need smaller, flexible platforms financed by probably, I don't know, by somebody else, donations or whatsoever. So Haro, what do you think? Where is the money coming from? How is it in Japan?
Yeah, so it's yes, a very, very, very difficult. So nobody can say an easy conclusion. But so now it's time to anyway collaborate the surgeon and the endoscopist together. And we are looking for some nodes, second generation, I believe. So so as Nagi mentioned, the flexible endoscopic surgery has some advantage, big advantage compared to conventional surgery. In my talk, I said that the flexible endoscopic surgery will replace the surgery, but not a real replace. Sometimes superior. Some flexible endoscopic surgery is a superior than surgery. So, for example, the Nagi said that the myotomy for diffuse esophageal spasm, that is a endoscopic approach is a far better than a surgical approach. So, like that, so flexible endoscopic surgery has a big advantage. And on the other hand, lymph node dissection, so systematic single lymph node dissection, maybe we can do it flexible endoscope. But if we want to do a systematic, so compartment dissection in a bigger field, so at the time, so collaboration with the surgery is mandatory. So I think yes. So Nagi mentioned at the very end of his slide, it's a flexible endoscopic surgery room, minimally invasive surgery room, including a flexible endoscope and the laparoscopy and the trachoscopy. It's a future, I think. We can do something. We can do something. And I hope the company, so almost 15 years has passed since the advocation of the node's original concept. 20 years.
20.
20.
Yeah, 20.
Has passed. So now I think again the company industries are thinking about the future minimally invasive surgery.
Okay, Nagi, but do you think there are places in the world where there could be labs where people could go and try their ideas? And again, where, for example, in your country, at your institute or wherever,
yeah,
how do you envision that's going to be financed?
Yeah.
Would we have to take research money from basic research, or what's the option too?
So we have actually thought about it very seriously, because this is one of my thinking or concerns for some time now, Thomas. So what we did is we created in our hospital a large animal lab now, where these procedures could be done. And we have set up a faculty of engineers. Now these engineers are part of the hospital faculty, like doctors. We have a group of engineers. They're very bright people who have passed out from the Indian Institute of Technology, which is like MIT. In US, we have IITs. They are engineers who passed out from that. We are giving them a large space and workshops for them to work out. So the idea is that any doctor, anybody gets an idea, or surgeons or physicians, we go to them. They have this workshop where they can make the device very quickly. We go down to the animal lab, which is in the basement, and then work it out, and then get our ethical permissions before we start on humans. So we started to do this cycle very quickly, so that within 6 months we can work out our instruments. We're coming out with some very exciting instruments, and the funding is predominantly from the Department of Biotechnology, which is part of the Government of India, Indian Council of Medical Research, Indian Institute of Sciences, which is a university, and private philanthropy. We are asking pilot for it. So all of them are contributing, and we have some fund for that. So we believe that over the next few years, this is the way we should advance, because depending on industry, we actually did a little with the industry, but I don't think we'll progress very rapidly, because they're looking at when this device can get into quick this thing, and when they're going to make the returns. Here, we are not answerable to anybody. The funding people do not ask us, what did you do? What happened? Did you get nothing? It's just free funding that's done purely for. So hopefully we'll be able to generate enough funds, and hopefully we'll be able to attract people like you or Harrow to come over and spend a little time to help us with this.
Okay, Haru, you are the boss. I think we're probably running out of time, and this seems to be a nice conclusion. So I don't think we are short of ideas, but we are short of infrastructure. And after sitting there and waiting and becoming more and more impatient, I think it's greatly welcome that somebody takes the initiative and invites other people. So thank you very much. And Haru, you are the boss. Maybe you wanna conclude this session.
Yeah, Thomas, I totally agree with you. So we have lots of ideas, and then Nagi also mentioned that we use we collaborate, make a team and collaborate with a company, and some funding, and we realize our dream. That is a big benefit to the patient and the society. So thank you very much, great masters. It's my great honor discussing two of you. So thank you so much.
Thank you. Bye-bye, guys.